Hi everybody, Ziv Simon here. I'm the creator of Surgical Master. Welcome to this video. And this is part 3 of a video series on the best way to treat a recession on a canine. In the previous videos, I talked to you about the recession lesion sent to me by Dr. Domik from Zagreb, Croatia. It was a Miller Class 1 with minimally attached and keratinized tissue, recession both on the premolar and the canine. And I talked to you about the two good options that we have here for this case, the connective tissue graft and the tunneling technique. And in the previous video, I showed you the different steps for a connective tissue graft. And if you didn't watch it, go back and watch it so you're aware of all the options. If you're considering a tunneling technique, the first step of creating a receptive root is the same. Any grafting procedure requires you having a root that is receptive for new tissue, meaning a root that is free of any restoration and contamination, caries, and calculus. So flattening the root surface and debriding it, both with hand instruments and rotor instruments, is very important for the success. Now, the tunneling technique is a little bit more technique sensitive. It requires a little bit more experience and training, but also using the right instruments to make it easy. Actually, you need to use a dedicated set of instruments for tunneling. The procedure itself starts with an intracellular incision around the teeth that have the recession and also the adjacent teeth. And that can be done with a dedicated tunneling instrument or with a blade, microblade. But I recommend you invest in the proper tunneling instruments to make this procedure much more predictable and minimize the risk of tearing, which is the number one problem with tunneling. The tunnel preparation starts from the sulcus into the mucosal part. So you'd like to take your time and work your way in a coronal direction, almost in a circular pattern. So you slowly but surely detach the tissue in full thickness all the way until you reach the mucosa. Don't try to stretch too much. Just start with 1 or 2 teeth and slowly expand to the other ones. And the idea is to have eventually a tunneled area that extends between the teeth, sometimes a full quadrant or full arch. And only when you tunneled enough, laterally and apically, you can reposition the tissue in a coronal direction. The problem that I'm seeing with a lot of dentists, number one, they're rushing to create the tunnel. That creates the problems, the perforations and the tearing of the overlying gingiva. And number two, they don't tunnel enough. They don't get enough flexibility of tissue to allow the coronal repositioning. Another important step is to tunnel under the papilla by using a dedicated instruments without separating it. Again, this is one of the risks of tunneling, separating the papilla. So with a dedicated curette or instrument, you can, from within the tunnel, lift the papilla almost to the palatal aspect in this case, and that again will allow you to coronally reposition and secure the tissue at a new level. So the first step and the most important step is a proper tunnel preparation, and then depending on the procedure, graft insertion and stabilization. That's again, it's a little bit of a tricky part. If you're using alloderm, the alloderm tends to flip inside the tunnel, so you need to find a way to stabilize it and then secure it with sling sutures underneath. Sometimes we don't even need to suture it. And then the flap gets coronally repositioned and sutured in a continuous sling suturing technique. So that's basically the essence of the procedure. I gave you the short version. It looks kind of simple, but it is tricky and it requires a lot of patience and training. And it can be mastered, but before you get into tunneling, I recommend you focus more on basic connective tissue grafting, free gingival grafts, get experience with coronal advancement of flaps and tissues in split thickness, and only then get into tunneling, which is again a little bit more technique sensitive. It works extremely well. And if you know how to tunnel, that will improve your implant surgery skills and bone grafting skills. So I look at it as a package. If you learn one skill, it's not good enough. You need to learn different techniques and different applications, get the experience And that's really the key to be good at surgery. If you're interested to learn a little bit more about tunneling, I have 2 videos online, and basically just put my name on YouTube and tunneling, and you'll be able to watch them. I'll give you a little bit more information, and you'll see the actual procedure. So I hope, Dr. Domik, this video series was helpful to you in deciding on the approach. Now, regardless of what approach you'll choose for your case, one limiting factor, one challenge is really the mucosal pull and sometimes a frenum that apply forces in an apical direction, which is the exact opposite of what we're trying to achieve, and many times is responsible for the treatment relapse and recurrence of recession. So just be aware of that. And even after all these years, I still didn't find a good way to eliminate the mucosal pull except for doing a frenectomy, which has its own disadvantages. When you think about grafting, it can create some scar tissue and limited vascularity. But I believe that once you perform a tunneling procedure or a connective tissue graft procedure, you need to undermine this frenum and extend your preparation beyond it. But it's definitely a challenge for all grafting cases. So there's a lot more to learn about grafting. I talked to you about the connective tissue graft and the tunneling. I gave you some guidelines, but there's a whole lot more to learn. The incorporation of growth factors, how to use an alloderm or allogeneic material, the pinhole surgical technique, of course, and the Vista technique, and also how to apply soft tissue techniques around dental implants. Totally different, more challenging, and not always predictable, but very exciting to see all the different opportunities that we have to help with patients' problems. And for that, we need more training and learning, getting educated and practice more. I hope you found this video very useful for soft tissue grafting techniques. Dr. Domik, thank you so much for sending me this case, bringing it to my attention. I hope it was helpful to you. Feel free to share it with your other Croatian dentists, and anywhere you're at, feel free to post it on social media. The Surgical Master community is growing really, really fast. So if you're not part of it, feel free to go to surgicalmaster.com, fill your name and email so you get my weekly emails and blogs, and I'll see you in the next video.